three of the things that we would hope that most EMS staff or emergency physicians would check for when examining a patient for stroke would be facial weakness, weakness of limbs, and speech or language dysfunction. In terms of examining the face, part of that is just observation and just seeing if at rest there appears to be drooping of part of the face. The nasolabial fold, which connects the nose down to the corner of the mouth, is often flattened on the side that's affected by a stroke. So that can be seen by simple observation. If a patient can participate in the examination, it's often helpful to ask them to smile or show you their teeth like this and see if there's any asymmetry or decreased movement of part of the face. Again, sometimes patients aren't able to follow commands or participate, so again, observation and seeing if they move their face when asked to talk or when stimulated in any other way can be another way to assess for facial weakness. In terms of drift or weakness of the arms, we ask that patients put their arms out in front of them at roughly a parallel to the floor, and what we would hope to see is no significant drift or dropping of part of the limb. If there is weakness of part of a limb, what we'll often see is a slow drift of part of the limb down to the body or down to the stretcher. If sometimes people are sleepy or unable to contribute, sometimes there can be droopiness of both sides at the same time, which is a little bit hard to interpret, but is not as indicative of a stroke as would be weakness of part of the body or one half of the body. And then last, in terms of evaluating speech and language, probably the easiest thing to do is ask people to repeat a simple phrase. One phrase that could be used is, "The sky is blue in Rochester," or any other number of phrases. People who have frank language abnormalities may not be able to repeat the phrase at all, which is often indicative of a stroke. Alternatively, people may be able to repeat the phrase but will have slurring of their words or dysarthria, which can also be indicative of a stroke. Well, any history that can be obtained is obviously very helpful to us. I think far and away the most important thing that can be established about the history of the event is the time of onset. As of right now, we only have IV thrombolytic therapy, which can be given out to 3 hours as the only FDA-approved therapy for acute stroke. So establishing a time of onset, especially if it's within 3 hours, is extremely helpful to us. I think any other history that can be obtained, for example, of trauma, was the patient found on the floor, was there anything that might contraindicate the use of TPA, is obviously very helpful to us because we have to make a decision very rapidly, and the more history we can have, the better off our decision process will be. I think one thing that's also very helpful is to inform us of whether there's any family members available or whether any family members may be en route, because that's something that we often need. We often need extra history from the family in terms of past history or other time of onset questions that can help us decide whether TPA or any other therapies are indicated. I think the last thing that's helpful to ascertain if it's possible is medication use, because warfarin, for example, is one medication that if a patient is taking and has an INR that's higher than a certain level, we actually cannot give TPA. So if the medications that a patient's taking can be very quickly learned, that's very helpful for us. That can be tricky, and I think it's very important that people realize that time of symptom onset is the last time that someone was seen normal. I think the most common scenario we see is when people wake up with their symptoms, and they wake up at, for example, 7 o'clock in the morning, and people describe that as the time of symptom onset. Actually, symptom onset was then the last time before that the patient was seen normal. If they went to bed at 10 o'clock the night before and were neurologically normal at that point, and then have symptoms when they wake up at 7 o'clock the next morning, it's very important to realize that we have to use the last time seen normal, which would be 10 o'clock the night before, as the time of symptom onset. We don't at this point have a good way of determining whether those symptoms began right after that person went to sleep or right before that person woke up. So we have to assume the last time they were seen normal as the night before. So when EMS is seeing a suspected stroke patient, it's very important to make that distinction as to whether the person really had symptom onset at a certain point, or whether they woke up with their symptoms at that time point, because that is often a deciding factor when we decide to pursue either TPA or other options.